certified in nephrology and internal medicine. He went back to school and completed a one-year fellowship in geriatrics at Michigan State University. Last fall, I'm very happy to say, because I get to work with him, he accepted a post as a geriatrician at St. Vincent's Healthcare and St. John's Lutheran Ministries joint venture, our clinic, the Center for Healthy Living. And he moved with his family to Billings, where he's going to stay forever. Dr. Rosenbaum's practice emphasizes improving the functionality of his senior patients rather than curing specific diseases. I'm very pleased to welcome him, and I ask that you do so also in his presentation, Cognitive Impairment in the Elderly. Dr. Rosenbaum.
Thank you very much. Well, Julie, thank you very much. Very pleased to be here. I want to thank the sponsors of the meeting today for inviting me. We've enjoyed being out here in Montana over the last few months. One of the reasons that I came out, just so you know, is that my colleagues, Dr. Eaton, Julie Pullen, and Jordan Teller, promised me that if I ever lost my marbles, they would help me look for them. And that was really a key selling point. We're going to talk about the concepts that make up dementia and the road to dementia, and some of the issues about it, and some of the things that you may come across in your daily activities. Now, one of the questions I had in looking out at the audience is, how many physicians are here? That many, huh? How many of you want to be physicians? That many, huh? Well, you guys are making it tough. In any event, I've been vested with the power from the state of Michigan, which is right next to Montana, to make you all doctors. And if you get your pencils and papers, we're going to present a case to you, because at the end of this discussion, you're going to end up being the decision makers. Okay? A 65-year-old man, accompanied by his wife, presents to your office with the following history. About a year ago, they went to his primary care doctor's office with complaints about recent onset memory loss. The patient was really less aware of this than his wife, who stated that he never listens. Now, who ever heard of that? He never listens to me. He forgets everything she says to him. Now, I didn't know that was a medical problem, but I did. After I went through the fellowship, I understood that became a medical problem. She can look him in the face and he forgets. Now, have any of you had that problem? The patient was in otherwise good health as far as he knew. Physical exam and routine laboratory studies were unremarkable at that time. A diagnosis of early Alzheimer's dementia was made, and Aricept or donepezil was begun. A few months later, the patient began to experience syncopal episodes. Whoa. Cardiological workup demonstrated bradycardia with heart block, requiring a permanent pacemaker, and one was placed. Despite 10 milligrams of donepezil daily, he continued to be forgetful, although very pleasant, without behavioral issues. He and his wife self-referred to the geriatric subspecialty clinic at Michigan State University. Although the wife's history was quite helpful in recounting what happens when his wife talks to him, the patient offered that sometimes when she spoke, he could understand her perfectly and remembered her requests, and sometimes he could not. Sometimes when she spoke, all he could remember were some popping noises in his head. Physical examination at the time was unremarkable, but other laboratory evaluations were obtained along with neuropsychological testing, and another consult was obtained. Now, your job at the end of this discussion is to figure out what we ordered, why, and who we referred the patient to. Okay, that's your task, so I want you to keep it in mind. Now, I don't know how well this slide projects, but the current DSM-4 criteria for the diagnosis of dementia are as follows. Number 1, there should be a memory impairment, confusion, forgetfulness, and at least one of the following have to be present as well. Elements of aphasia or word fluency, apraxia, agnosia, disturbances of executive functioning. Additionally, these disturbances in memory and other areas listed under number 2 must significantly impair or interfere with work, social activities, or relationships. So these criteria must be met before a diagnosis of dementia can be made. Now, additionally, there are some other criteria of the Alzheimer's type dementia. It's a gradual onset, but it's a continuing cognitive decline. So once that diagnosis is made, if it's accurate, it begins a constant descent over a number of years into eventual oblivion. As opposed to things like vascular dementia, which have a focality to it. It may occur in a stepwise fashion. There may be periods of plateaus that may last for years. So they have different patterns. Additionally, Alzheimer's and vascular dementia are not the only dementias. There are dementias that are defined by Parkinson's disease, by HIV disease, head trauma, Huntington's chorea, Pick's disease, prion disease, Jakob-Creutzfeldt, etc., alcohol. So it's not that dementia is all Alzheimer's and functions just like Alzheimer's. Not that way at all. The major types we've just mentioned, of course, Alzheimer's. Vascular dementia is the next most common. If you live in England, the English would believe that the two of those are together. But we live in America, so we kind of like to split it out. But in reality, that ain't necessarily so. Dementia with Lewy bodies, that's relatively common, very hard to diagnose, usually comes along with elements of Parkinson's. Of course, then there's Parkinson's disease with dementia, which is different than Lewy body. There are frontotemporal dementias. There are reversible dementias. Now, these are going to be important, especially for those of you that interface with patients and working with or screening or ordering medications, because you're going to want to know what's reversible and what isn't. I think I went one too far. The minor types are alcohol-related dementias, the medication side effects. Many of the medications that we use have tremendous impact on cognition. They can create hallucinations, delusions, what have you. So anytime you're up against an issue of cognition, always look at the medications, always look up the side effects, especially in the central nervous system, and see how it might relate to your patient. Depression. And we heard about that yesterday. And I'm here to tell you from a clinical standpoint, depression is ubiquitous. Depression's like Chicken Man. It's everywhere. So anytime you come up against a patient with cognitive issues, depression is going to be a significant question to be answered. We're going to talk about it at the end a little bit because I wanted to add on what we heard yesterday. And for those of you who are clinically involved with patients, there's some things about depression that you should be aware of. We'll talk about that. Additionally, CNS illnesses like progressive supranuclear palsy are associated with cognitive changes and can look like dementia. Now, in terms of the risk of dementia, it's more common in African American females than males, Caucasian females, and lastly, Caucasian males. That's the incidence over time. Now, prior to getting to dementia, because you don't wake up one morning and you're demented, unless you have a lot of kids. And then, it could happen. I know it happened. Look at me. It's happened. In truth, dementia is not a dichotomous state. So today, if you're normal, tomorrow you're not going to wake up demented. It's not going to happen. However, there's a segue. There's a middle zone. There's this kind of a in-between. We call that mild cognitive impairment, minimal cognitive impairment, however you want to term it, cognitive impairment. But it's a heterogeneous state that's intermediate between normal cognition and dementia. It's a state that does not meet the definition of dementia, which I gave to you. Very specific. You can look it up. You can have a copy of it with you. Now, I will share with you, as we go through MCI, that when the DSM-5 comes out, it may look different than the DSM-4, because it may begin to delve into mild cognitive impairment and possibly some markers that are being looked at to try and identify who with mild cognitive impairment may go on to Alzheimer's, who may go on to other types of cognitive problems, and who just got it from their kids, because it's true, insanity is heritable, and you do get it from your kids. And you guys think it's a joke. But Julie and I went to a meeting in February in California, and this nice lady, the psychiatry lady, gets up there and clearly proves the case for late onset schizophrenia. And she presented two cases, two 55-year-old women who developed clear schizophrenia in late age. And both of those ladies had 5 kids. And I said, hey, it proves the case. In late age, you get it from your kids. So that's it. Anyway, MCI criteria include a measurable deficit in cognition in at least one domain, in the absence of dementia or impairments in activities of daily living. Now, this is a slide taken from the New England Journal, and at the top of it, it says something called the CDR. Now, there's some handouts that apparently are on the internet, so if you're interested at some point, you're able to go onto the internet and you're able to pull up a copy of what's known as the Clinical Dementia Rating Scale. And what it does is that it has 5 areas of impairment, one of which is memory, one of which is orientation, judgment and problem solving, community affairs, home and hobbies, personal care. And at the top, it has none, questionable, mild, moderate, and severe. So when you see a patient, like the gentleman who was brought to us at the beginning of this presentation, you can do a CDR rating scale with the family. And you can figure out where they fit along this line. So they may be at a CDR of 0, and they have normal aging, a little bit of forgetfulness, like, I almost know who you are, but not really. That kind of thing. When you talk to your mom, your dad, they say, oh, June, July, But some of that's normal, and some of that is not so normal. And this helps you try and figure out which is which. As you notice, as people progress along into Alzheimer's disease, things begin to change. CSF protein change, and tau protein in the spinal fluid. You can see a decrease in beta amyloid, etc. Now, at this point, research activities. So I'm not going to do a spinal tap on you, believe me. But there may come a time when there are markers and we're able to discern the different levels of either these proteins, other proteins, precursor proteins, so that along with certain symptoms and certain biochemical markers, then we may be well able to